Now we're going to go into the acute coronary syndromes. And we've changed this around a number of times to try to make it as simple as possible for you. So we'll be very anxious to see what you think about the current way that we're going to present this. But again, we're going to call my colleague, Dr. Peter Pollack, up from Jacksonville, who works in the catheterization laboratory, to talk about the assessment and reperfusion therapies for patients with acute coronary syndromes. Now, let's first go to these questions and see what you do for answering the questions. We've got a 70-year-old man presents with intermittent central chest pain beginning at rest and is now pain-free. He takes aspirin for arthritis, treatment for diabetes and hypertension, heart rate's 90, blood pressure's 112, exam is unremarkable except for an expiratory wheeze. His ECG is shown. His troponin is 0.5. His creatinine is 1.8. Okay? Now, which statement best characterizes his presentation and risk assessment? So we're talking about low risk unstable angina, low risk non-STEMI, intermediate risk non-STEMI, high risk non-STEMI, or a STEMI. So let us see what you think this gentleman's risk is at presentation, which is important for stratification. So go ahead and punch in your answer. And let's see your answer. All right. Next question. Based on your risk assessment above, what's the next best step in the management of this patient? 325 of aspirin, 180 of ticagrelor, unfractionated heparin, urgent angiography. 81 of aspirin, 600 clopidogrel, unfractionated heparin, stress echo. 81 of aspirin, 600 clopidogrel, unfractionated heparin, or coronary angiography within 24 hours. Aspirin 81, prasugrel 10, unfractionated heparin, metoprolol for medical therapy. Which one is the best? Punch in your answer. Okay. Next, the patient started on aspirin, ticagrelor, unfractionated heparin, plans for angiography in the morning. At 11 a.m., you're notified he has intermittent episodes of chest discomfort despite a nitroglycerin infusion. A new systolic murmur is noted at the apex. He has no venous distension or rales, but his blood pressure is down to 95, heart rate is 85. What's the next best step in management? Increase the nitroglycerin dose, cardiac surgical consultation, echocardiogram, call to be first case in the morning because it's 11 p.m., or take him to the cath lab now. Okay, let's see the answer. All right. Number 4, you work in a community hospital that's 60 minutes away from the nearest referral center. You have a 60-year-old guy come in with PAF, awoken at 11 p.m. with left arm discomfort, chest fullness, and mild dyspnea. It's persisted for 30 minutes. He presents to your emergency room 45 minutes after the onset of symptoms. No other complaints, just flew to Hawaii for 2 days of a business meeting. Returned 3 days ago. He's on metoprolol, apixaban, atorvastatin, digoxin. He has no medical or food allergies, and his examination is normal. He was started on 2 liters of oxygen, given aspirin, morphine, now pain-free. Hemoglobin 13.8, white cell count a little bit up, D-dimer a little bit up, creatinine 0.9, glucose a little bit up, pulse ox 97%, chest x-ray normal. Your troponin's still pending. You're called to see him. He's got this electrocardiogram here. What's the best treatment? Start unfractionated heparin, get a CT pulmonary angio, get a stat CTA for a triple rule out, transfer to referral facility for angiography and coronary intervention, give unfractionated heparin bolus TNK, then transfer, unfractionated heparin and admit to your ICU, knowing that you do not have a cath lab there. What are you going to do with this patient? Okay, let's see. All right. So let's call Peter up and talk to us about reperfusion strategies in the acute coronary syndromes.
So no relevant disclosures, I think. We have 4 learning objectives to get through, and really the talk can be divided in half. The first half is NSTEMI, the second half is STEMI. And in the first half, we're going to look at the evaluation and triage of acute coronary syndrome, and in particular, how to incorporate risk stratification scores into your decision making. Then we're going to look to identify patients for early invasive versus a selective approach in NSTEMI. So who goes to the cath lab and when. And then the second half of the talk is really about STEMI, and we're going to select the optimal reperfusion strategy for patients with STEMI. When do we use lytics? When do we use primary PCI? And then describe the optimal use of the pharmacoinvasive strategy and hopefully demystify any confusion about that. So if we just look a little bit at epidemiology, there's greater than 5 million ED visits with chest pain. This is our bread and butter. We all see this all of the time. 1.5 million patients admitted with acute coronary syndrome. That means that just in the time I've been going over this slide, someone's probably had a heart attack somewhere at one of your referring hospitals. And most of these have shifted. So the population, as we get more penetration into the population of optimal medical therapy, we're seeing a shift from STEMI presentation to NSTEMI presentation, and it's taken over. So the bulk of the patients that we see with acute coronary syndrome are now NSTEMI, and this is important because NSTEMI, while not as urgent and perhaps acute as STEMI, when we think about it, it does carry a higher mortality rate. And that's because the patients are sicker. So if we think about our NSTEMI population, all the patients with multivessel disease who may have demand ischemia, those with, it involves more vessels in general as opposed to STEMI, which is more often a single vessel pathology. STEMI may be more time sensitive, but in general they have better survival. And it's important to keep that in mind as we're looking to risk stratify. Now, if you look at the different options in anticoagulant choice, oral and IV antiplatelet choice, cath strategy in patients with NSTEMI acute coronary syndrome, there's a fair bit of complexity. This is over 250 choices when you multiply it all out, and we're going to try and break down exactly how to pick each one for the right patient. The guidelines from 2014 are our guiding document for most of this talk. Really not much has changed, which is important. I like to think of as a central guiding principle here this kind of continuum of coagulability. If we look at the pathobiology that's underlying what's happening in the coronary bed as we move from stable ischemic heart disease with progression of plaque to plaque rupture and thrombosis in the acute coronary syndromes, and the degree of platelet activation and coagulation cascade activation moving from unstable angina to NSTEMI and then to STEMI with complete vessel occlusion, we're going to see as we move along this arc greater benefit of stronger antiplatelet drugs, stronger anticoagulants, earlier intervention. So the greater the acuity, the more benefit there is to earlier intervention and stronger medicines, but also the greater the bleeding risk that comes with those therapies, thus the need for risk stratification. Bleeding, of course, increases mortality, and these aren't people that are hemorrhaging to death, but what do we do when somebody bleeds? We stop all of the therapies for their thrombotic process, and we give them blood. All these things increase their mortality. You can see, especially with non-access site-related bleeding on the far right of the screen, there's a significant mortality penalty to any bleeding that happens, and so we have to think about someone's bleeding risk as we apply these therapies. So our first learning objective is to focus on the evaluation and triage of patients with acute coronary syndrome and to apply risk stratification scores. If we start with a diagnosis of NSTEMI, these are patients with prolonged greater than 20 minutes of anginal ischemic type chest pain that occurs at rest rather than with activity, new onset Canadian class 2 or 3 angina, or an exacerbation of a stable angina pattern. This can be somebody who, well, usually I can walk around the block, but now as soon as I get out of my chair, I'm starting to have chest pain. So an exacerbation of a stable pattern in the setting of a positive biomarker. If we look at their ECG, it can be normal. They can have classic ischemic ST depression, as we saw in our earlier question, or even transient ST elevation, T-wave inversions. Most of these add specificity to our evaluation when present, but don't have to be present. So the way I approach the initial assessment of suspected acute coronary syndrome is I ask myself, is this plaque rupture and thrombosis? This is how we address the likelihood that this is a thrombotic process in a coronary vessel. And we have to stratify this between low, medium, or high likelihood of a coronary event, or could it be a demand event? Could it be an alternative explanation? And then when we look for the prognosis of ACS, I focus on how much heart muscle is being affected by this coronary event. And that guides the intensity of medical therapy and how soon we need to act on with invasive therapies. This is stuff you all do and know every day. So we're going to look, these are tools we have at our disposal are listed there. The history, the physical exam, the chest x-ray, the ECG. We're going to look for both confirmatory and alternative explanations. We're going to use biomarkers, predominantly troponin. We're going to repeat them every 3 to 6 hours. We're going to look at the trend or rise in the troponin. Is this a stable troponin elution in the setting of a demand? And we're going to incorporate these into risk scores. There are a number of these. We'll focus in this talk on the TIMI and GRACE scores because they're the ones that are used in the guideline most often. There are other risk scores that are out there and have been validated as well. If we just look at troponin rise, this reflects the amount of myocardium that has been affected or is in jeopardy, and so it correlates with death at 42 days. So the higher the rise in the troponin, the greater the acuity in the patient with NSTEMI. But troponin is specific for heart muscle, not the cause of what's injuring the heart muscle. There's a lot of words on this. The whole point is that there are lots of non-coronary reasons that someone may elute some troponin into their bloodstream. We all know this. We've all had consults for troponinemia, and that doesn't mean that it's necessarily a coronary event. This has implications because our therapies generally target the causative mechanism. So we need to match our therapy for a coronary to a coronary event. The TIMI risk score is easy to calculate in your head. It's 1 point for each cardiac biomarkers, 2 episodes of chest pain, 3 coronary disease risk factors, age greater than 65, aspirin within 7 days, suggesting that they're having platelet activation in the setting of an antiplatelet drug already, prior known coronary disease or ST segment deviation. These add specificity to this being a coronary process, and it's been validated in a number of different trials. The higher the TIMI risk score, even though a number of us in this room probably have a positive TIMI risk score, we're not actively having chest pain, hopefully other than me. So as the TIMI risk score goes up, the risk of all composite endpoints also goes up because this is more specific to a higher risk and more specific to a coronary event. The GRACE risk model nomogram you can't do in your head, so we won't ask you to, and the boards won't ask you to, but they'll ask you to apply the number to risk stratify people. So you can calculate this using your phone or an app, or you can use the paper nomogram if it's around, but I think it's important to know what to do with the number when you get it, and to incorporate that into your decision making for what to do with the patient as far as early invasive approach versus a delayed invasive approach. I'll explain the data behind that. Our second learning objective is how to decide between an early invasive and a selective or ischemic guided therapy in patients with NSTEMI. So invasive or conservative strategy, if it's early after lunch and you're going to doze off for a little bit, focus on this slide. Extensive comorbidities or refused consent. So these are patients where you have to take a big picture approach, right? So if the patient's too sick to benefit from what you're going to do in the cath lab, be conservative. If they refuse to go, we don't do this above people's objections. If they have a non-diagnostic ECG and negative biomarkers, it's unlikely to be a high-risk coronary event. Figure out whether it's a coronary event with risk stratification and stress testing, and then consider what to do based on those results. And really everybody else, positive biomarkers, you think it's a coronary event, they should go to the cath lab in an intermediate range of time. And we'll add specificity to this, but this will get you most of the way when you're making your decisions. Caution, because the dye we use in the cath lab is nephrotoxic, so if patients have their kidneys in jeopardy, then we have to be considerate about that. Always important as we're studying for boards to bear in mind the class 3 indications. The first one here, extensive comorbidities, these are people that just aren't going to benefit from being in the cath lab where the risk of going to do an invasive procedure is too high. The other one, low likelihood of ACS, troponin negative, especially women who have a slightly higher risk from the procedure itself, we're going to want to consider a non-invasive risk stratification first. Now, a slightly busy slide, but the important point here is that all of the weight of evidence really favors an early invasive strategy in most people. And I think that's the mindset to bring into the boards is if you're not going to the cath lab at a reasonable time, why? And there are reasons, as we just talked about, not to, but the default strategy is going to be an early invasive strategy because there's a 25% relative risk reduction in mortality over 2 years in patients who are having a coronary event. And this is seen as the risk goes up, the benefit to going to an early invasive strategy also goes up. The number needed to save a life, around 62. Almost all patients are eligible. We have to be mindful of the few that aren't. Again, higher risk, greater benefit of an invasive strategy. Value of the risk scores that we have. And then timing of intervention in acute coronary syndrome. This was the TIMAX trial. This is where the GRACE score really has its meat. And the number to remember is 140. So a GRACE score greater than 140 are those patients who are at high risk. If we look at, those are where the curve separated with an early strategy. Early meant kind of today or early tomorrow. It was a median time of 14 hours versus 2 days from now. So if you have a high risk and it's a Friday, well, maybe you shouldn't wait till Monday. If they were low or intermediate risk, there wasn't an advantage to an early strategy. Now, this was carried even further in the ABORD trial, where they tried to see if you treat N-STEMI like STEMI in high-risk patients, is there an advantage? And there isn't. Their endpoint was looking at troponin rise. It didn't work, so 70 minutes versus 21 hours. This is kind of saying, well, should we treat an N-STEMI emergently and get reperfusion? In the face of modern optimal medical therapy, there wasn't a benefit even in just how high the troponin went. If you take on a meta-analysis at all of these trials, there's no benefit to cooling off, so don't wait an extra period of time. Cath has gotten pretty safe, so there's no early hazard, and you get less recurrent ischemia for those hot lesions that you're now treating with PCI in the lab. There are two different ways that you can put together this early invasive versus ischemia guided strategy from the boards. This slide, the next slide, I'll leave in your handout for reference, are two ways to break it down. The next slide is a decision tree, but they contain the same information and they tell you what to do. So the first thing to think about is somebody unstable? So even if they're not a STEMI, if they're an N-STEMI, but they're quite sick, so they've been on medical therapy, they have refractory angina, you just can't get them pain-free, they have new heart failure, new or worsening mitral regurgitation, hemodynamic or electrical instability, they've declared a degree of risk that involves clinical instability, then those patients need to come to the cath lab within a short period of time, within a couple hours. Then if you take low-risk patients, these are the folks that should go for an ischemia-guided strategy. So a selective invasive approach. So you're not going to cath all of these patients. This is where it may be something that's not coronary, maybe a different pathology is going on, or they've just got quite a low risk going into this. So low risk, particularly troponin negative females, so that they haven't injured their myocardium. We're going to follow an ischemia guided strategy. An early invasive strategy, these are people you want to cath within a day. GRACE score greater than 140 once again. They have a troponin rise, ST depression. These are your classic, it's clear, it's a coronary event. They should come to the cath lab. And then there's this delayed invasive strategy. These are patients that are very likely to have coronary disease. So a high enough pretest probability that even a negative stress test is unlikely to shift your pretest probability that this is a coronary event. Well, they should also come to the cath lab. You have to weigh the degree of risk and benefit with their renal disease. But those, if they have diabetes, high likelihood, high pretest probability of coronary disease. If their EF is low, we need to see whether this is ischemic. If they've had PCI or CABG before, then we should see whether this is part of the culprit process. Remember to reevaluate patients. You can cross over from one strategy to the next. If you're in high risk, you're planning for later, and to go to the cath lab, and then the patient declares that they're unstable or they have new clinical instability, then call and go to the cath lab emergently. This is the same information presented a different way. In case you digest it better that way, you can look at it, but we don't need to repeat it. Some pearls, just to summarize the first half of the talk for NSTEMI. Early risk verification and prediction are essential in order to apply appropriate therapy. So use the risk models. They will help you make the right choice, especially on the boards. An early invasive strategy is preferred in high-risk patients, including women, because these high-risk patients wouldn't be troponin negative. Within 2 hours if they declare clinical instability, 12 to 24 hours if they have a high risk score such as GRACE greater than 140. This will be calculated for you. Within 72 hours if they have other risk factors, they just need to be cathed before they go home. And you can cross over, so it's important to clinically reevaluate. Don't forget optimal medical therapy. All of these patients need optimal medical therapy before they're discharged. It's a quality metric. All right. So the next half of the talk is for STEMI. So we're going to first select the optimal reperfusion therapy for patients with STEMI based on their clinical characteristics. Our guideline is 2013. There's one important way that it's been updated, and I'll highlight with respect to multi-vessel intervention. If we start with the definition of STEMI, this is going to be ST elevation of 1 millimeter or 0.1 millivolts and 2 contiguous leads in a coronary distribution. Now for V2 and V3, it's important to note that it's slightly different between men and women because men tend to have bigger hearts and more voltage. So it's 2 millimeters in V2 and V3 in men and 1.5 millimeters if you can split half a box in women, but that's the formal definition. And new left bundle branch block. Left bundle branch block, as we know, is common in patients with heart disease. Bundle branch block presenting as STEMI does make the diagnosis difficult and will remain a challenge for us as we're making the diagnosis. It's important to repeat the ECG every few minutes if it's non-diagnostic, but you have a high index of suspicion. All acute STEMI warrant reperfusion therapy, so if they have a blocked clinical artery, they will do better when we open it, and we have to talk about how we're going to open it. So unless it's contraindicated or the patient refuses, or if they have limited life expectancy, they're too old or sick with other comorbid conditions, we should try to get reperfusion therapy in place. And then we're going to talk about the different ways that we can do that. This is a STEMI management algorithm you've all seen, hopefully from the guidelines. And I think there are a number of different number cutoffs, and this is where confusion often starts to set in. The door-to-needle time of 30 minutes at non-PCI capable hospitals and the door-to-balloon time within 90 minutes at PCI capable hospitals are just metric goals. So your hospital, whichever one you're at, is trying to meet that metric for timing. It doesn't influence decisions, really. The decision-making, the way that the questions come at you, are deciding whether to give lytics or to transfer, and that's based on the ischemic time. So first medical contact to balloon time to reperfusion of less than 120 minutes. So the 120-minute metric is where we might change our strategy, but the 30 minutes and 90 minutes are just going to be metrics that are goals for wherever you are and how you build your system. The door-in, door-out time, or DIDO performance measure, was created to create some quality metric jeopardy for transferring centers. So what the action registry showed is that if you get patients in and out quickly, if it's a facile system, then they do better because this upstream effect has an effect will affect their total ischemic time. Less ischemic time does affect mortality in the STEMI patients. Some definitions as we go through, just for clarity. If we're treating with fibrinolysis, that's thrombolytic therapy given as a standalone reperfusion therapy. This was what was done before primary PCI. Primary PCI implies that there is no thrombolytic therapy that is given. Rescue PCI is PCI after failed thrombolytic therapy. The pharmacoinvasive strategy only really exists at non-PCI capable hospitals. And this involves thrombolytic therapy followed by transfer for elective routine angiography plus minus PCI. So if you're at a non-PCI capable hospital, then the pharmacoinvasive strategy, and we'll talk more specifically about that in a couple minutes, it will be worth considering in certain patients. This is sometimes confused with something that was called facilitated PCI, where half-dose lytics was given immediately followed by angiography, and patients did worse. So there is this time period after exposure to lytics where patients should not go to the cath lab. If we go back to the early 90s and we look at large cohorts of patients comparing lytics to placebo in STEMI, opening the artery helps improve mortality. This was true for all kinds of STEMI, but not NSTEMI. So please don't give lytics for NSTEMI, no matter what you consider their risk to be. So why would we consider primary PCI? Well, these are the shortcomings of fibrinolytics. There is a ceiling we generally don't get. It doesn't open all blockages in the arteries. We got TIMI3 flow in only about 50% of vessels. There is problems with hemorrhagic complications with thrombolysis, about 1% intracranial hemorrhage that we just can't get below. There's also vascular GI bleeding. And then the elderly, these are the folks that tend to have the most to gain from reperfusion, but many of them have contraindications to use of thrombolytics to open their blocked artery. These, we talked about the contraindications to thrombolytics with stroke yesterday. These are slightly different. They're broken into absolute and relative contraindications. If you look at the relative contraindications that include any oral anticoagulant therapy, including the DOACs or warfarin, they are not considered absolute, but as you're looking at decision diagrams, I think of these as the people that are at high bleeding risk. So if you're at high bleeding risk, you then have to make a judgment about the benefit of and likelihood that the thrombolysis is going to open the artery and engender reperfusion versus the risk of bleeding in that patient. So when we think of thrombolysis versus PCI, they have different risk-benefit curves over time. Thrombolysis works best on the freshest clots. So fresh, fragile clots, there's this golden hour that exists in patients who manage to be in the hospital parking lot when their artery closes. And if they can get thrombolytics in to open that artery, especially if it's their LAD, quickly, they can do better even than PCI. Otherwise, very soon after, as time goes on, the benefit of primary PCI quickly outweighs thrombolysis because the benefit of thrombolysis goes down in comparison to the risk of hemorrhage with it. As the clots firm up, they're less likely to reperfuse. So that's when you need to start thinking about a pharmacoinvasive approach or just transfer for primary PCI. This is the Keeley and Grimes data, something that I think everybody in here needs to know, and this is why we do primary PCI over fibrinolytics when you can in a reasonable period of time. And you can see that for death or a composite endpoint of death, MI, and stroke, and especially for recurrent ischemia, primary PCI significantly better than thrombolytics as long as it doesn't involve a substantial delay. So primary PCI, once again, class 1 indication, best early reperfusion option if performed within the first 12 hours of symptoms. 12 to 24 hours, it can be considered. Beyond 24 hours, we get into the OAT trial, and we'll talk about that in a few slides. We're aiming for first contact to balloon when you arrive at a PCI-capable hospital of less than 90 minutes. It should be an experienced center, and ideally there should be surgical backup. STEMI with shock or severe heart failure takes the time metric out of the window. If you have STEMI and shock, then you should have PCI at any time. Now this is a brief digression related to a change in the guidelines because of new data. So in 2013, it was said that you should not perform PCI in a non-infarct related artery at the time of primary PCI. So these are standby lesions. The right coronary is occluded. The LAD has an 80% lesion. Okay, should you treat the LAD? It used to be a class 3 indication. A number of different trials came out, Culprit, PRAMI, Dynami, you've heard about these in the headlines. They consistently showed that there may be some benefit. There certainly didn't seem to be a harm signal, and so they changed the guideline in 2015 so that you could consider primary PCI in a non-culprit artery at the time of STEMI. There are still significant questions regarding the optimal timing of non-culprit PCI in STEMI patients. And so with that, I would say because of the remaining controversy, it's unlikely you're going to see a specific question other than to say it's not definitely the wrong thing to treat a standby lesion. So when we think about STEMI patients best suited for transfer, these are the patients that aren't going to do as well with thrombolytic therapy, people at higher bleeding risk. If they have symptoms greater than 4 hours, their benefit from thrombolysis starts to wear off. That's not to say we never give it, but you have to weigh individualized for that patient, their likelihood of benefit versus their risk. The decision to transfer is a judgment that needs to be made considering the time required. And again, our metric is to minimize the ischemic time to less than 120 minutes. So for learning objective 4, we're going to describe the optimal use of the pharmacoinvasive therapy arm in STEMI patients. And pharmacoinvasive means that they get full dose lytics. So lytics are their reperfusion therapy. They also get 300 milligrams of clopidogrel, and they're transferred to get angiography 3 to 24 hours later. Remember, we learned from facilitated PCI that you should not go to the cath lab too soon after lytics. So you have to wait, 3 hours or so, but then cathing that patient within a day will improve their outcome. So pharmacoinvasive is at non-PCI capable hospitals. Patients who get thrombolytic therapy are then transferred to where they can get angiography in a reasonable period of time within a day. Some pearls just for the boards. We avoid glycoprotein inhibitors in patients who get thrombolytics, so that's going to be the wrong answer if it's an option. Again, avoiding early angiography. And then a nuance, this is all, the pharmacoinvasive strategy came from the transfer AMI trial, and they used a loading dose of 300 milligrams of clopidogrel rather than the higher 600 milligram dose that is more commonly given today. So that's the dose with this strategy. A brief word just about patients who present within that golden hour and have low bleeding risk. It is reasonable to go with thrombolytic therapy instead of transfer. If they have high bleeding risk or later presentation, then consider transfer. Again, if you cannot transfer to a balloon to have an ischemic time of less than 120 minutes, then that's when we're going to use thrombolytic therapy. If you use thrombolytic therapy, then you're still going to consider transfer as part of a pharmacoinvasive approach. So I leave this for your reference. This is straight out of the guidelines, and you can walk yourself through different scenarios. If you're at a PCI-capable hospital on the left side, go to the cath lab. If you're at a non-PCI-capable hospital, but you can get to a PCI-capable hospital within that 120 minutes, do it. Golden hour notwithstanding. And then the questions tend to get confusing when you're at a non-PCI capable hospital. Then the delay is going to be an ischemic time greater than 120 minutes if you are going to transfer. So that's when you're going to start thinking about lytics. You individualize for the patient's bleeding risk, give lytics, and then transfer still. That's the pharmacoinvasive strategy. So a few things, just some guidelines to end up with. For the class 3 recommendation, this is from the OAT trial. I think the important thing to acknowledge here is that if it's been more than 24 hours, think about the exclusions to this class 3 recommendation. So the artery is blocked, but the patient has to remain asymptomatic, and there has to be the absence of significant ischemia or any other signs of instability in order to walk away from it. So those were exclusions in the OAT trial for enrollment, and I think remain as exclusions in this recommendation to avoid PCI. Early angiography and PCI class 2B recommendation. So these are for standby lesions, as we talked about. And when we talk about stent placement, really anything that opens the artery is acceptable, and you have to stratify based on patient characteristics. So if there's higher bleeding risk, then we may consider bare metal stents over drug-eluting stents. The class 3 recommendation for drug-eluting stents is in patients, and in the STEM, if this comes at you on the boards, these are patients where it's clear they may not continue with their DAPT therapy. And so if you can't document that they're likely to be compliant with DAPT therapy or can safely take it, then those are patients you should avoid drug-eluting stents in acute coronary syndrome and STEMI. Intra-aortic balloon pumps and LV assist devices like the Impella device have class 2 recommendations, may be considered in patients who have shock and persistent instability. They all come with it's been difficult to show that there's any mortality benefit. They all have greater groin complication rates, so more bleeding. And immediate angiography is for patients if they've recently been dead. So these are out-of-hospital cardiac arrest, return of spontaneous circulation. Now they have a STEMI, treat them like a STEMI, emergent angiography, see if it was a coronary artery that was blocked that caused it. They should get therapeutic hypothermia unless they're back to completely normal mentation. To summarize a few board pearls for STEMI on the second half of the talk, early delivery of reperfusion therapy in all eligible patients reduces mortality. This is opening the artery helps. A pharmacoinvasive strategy can be considered at non-PCI hospitals. So after lytics, go ahead and transfer for angiography and PCI a little bit later, but within a day. Primary PCI within 12 hours is the preferred strategy given expertise and local logistics are in place. And then a systems-based approach is really essential. Again, it's that 120 minutes of ischemia that influences our decisions of what strategy to choose. And then know the contraindications for fibrinolytic therapy. They may be in a question coming in just a minute. So with that, we'll stop.
Come and have a seat, Peter. Okay, so you've heard about when to go to the cath lab, when to give medical therapy for non-STEMI and STEMI. Just to let you know, lectures 2 and 3 this afternoon are going to go over the different antiplatelet, antithrombotic therapies, beta blockers, so on and so forth. So Peter was first in knowing when to go to the cath lab, when to intervene. They'll be following with what drugs to intervene with. Now let's go back to question number 1. A 70-year-old man presents with intermittent central chest pain, beginning at rest last evening and is now pain-free, takes aspirin for arthritis and treatment for hypertension and diabetes. Heart rate's 90, blood pressure's 112, exam is unremarkable except for an expiratory wheeze, his ECG is shown, troponin is 0.5 and creatinine is 1.8. What statement best characterizes his presentation and risk presentation? Unstable angina, STEMI low risk, non-STEMI low risk, non-STEMI immediate risk, non-STEMI high risk, or posterior STEMI? Ooh.
So let's go through the 3 that are for the one case scenario, and then we'll have explanations.
Okay, so let's go to question 2. So this is still the same case. Based on your risk assessment, what is the next best step? And we've read through this before, so you read it and pick your best answer. Okay, better. Question number 3. Patient started on aspirin, ticagrelor, unfractionated heparin, and plans are made for coronary angiography in the morning. At 11 p.m., you're notified that he has intermittent episodes of chest discomfort despite a nitroglycerin infusion. New systolic murmur noted at the apex, no venous pressure aroused, blood pressure is down to 95 now. What's the next best step in management? Nitroglycerin increase, call a surgeon, do an echo, make sure he's first case in the morning, or take him to cath lab now. Okay. So, Peter, you want to go through the next few slides for us and kind of explain what your thought process was here?
Yeah, so I think this is a guy we were trying to describe a high-risk end STEMI. So he's clearly got ischemic changes in the ECG. He's got a positive biomarker. I think if you go through...
Go to the next slide.
I've got a couple of explanatory
right
slides.
Here.
There you go. So this is I've highlighted where his TIMI risk scores are positive. So he's got a TIMI risk score of 5, which is high risk. Again, it's not possible to calculate the GRACE score, but I think calculating a TIMI risk score is within the scope of the boards. But just knowing that this is a patient with high-risk end STEMI, this is, I think, a very prototypical example of a high-risk end STEMI, someone you'd want to cath that day or the next day, depending on when they came in, once they're on medical therapy. So
Yeah, quick and dirty though. If your troponins up and they have some ECG changes,
You're
they're
done.
high. Yeah, you're done.
Don't overthink it.
Yeah, don't overthink it. So just remember that. You see a patient, troponins up, the ECG has some abnormalities, go for it. Okay? Next slide.
This was his GRACE score. It calculates to 142. And the GRACE score is really worth looking at. It's more nuanced than the TIMI score. I think it's a bit more specific when deciding about things. It can help you if there are questions. But again, with the ECG is positive, the troponin is positive, I think an early invasive approach is the right strategy to use. So we can go on the next.
Next slide.
And this is just the implication of the GRACE score and the Timax data. You saw this in the presentation. These are the curves that separated. So when you did an early versus delayed approach in lower risk patients, there wasn't the same benefit. So this is the value of picking out the high risk patients to go sooner to the cath lab. And that's the point. That's what will be on the boards.
And I know your next slide is going to show it, but just while they're looking at this, your definition of early versus delayed timing-wise?
Yeah, I think this is a board took this to the extreme, right? They tried to treat high-risk end STEMIs like STEMIs, and there wasn't a benefit. So it's, within 14 hours, within, 24 hours is the formal recommendation, but it's same day or next day. Rather than a couple of days later. Yeah. That's the.
But if they come in at 2 in the morning, it's not rushing to be in the cath lab at 2 in the
Correct.
morning.
So if they come in overnight, do them the next day, unless they declare some clinical instability. And that was the point of that third question was we're trying to describe somebody who's got new mitral regurgitation, new clinical instability, and then going to the cath lab, shifting to an urgent cath lab, not waiting till tomorrow. At that point, I think is the right thing to do for that patient. So a number of people chose echo. Certainly you hear a new murmur getting an echo as you're calling the cath lab isn't wrong. And this is the differentiation between the boards and real life, right? Because the boards will always ask, what's the next best strategy? They want to know that you've activated the cath lab, not waited to activate the cath lab until you look with the echo.
Okay. So if we go to the next slide, let's reiterate. This is for non-STEMI now.
Yep.
Okay, so take us through one by one again.
So again, immediate invasive, this is within a couple hours. These are people you want to cath rather emergently, and it's clinically unstable patients, right? Much like STEMI is a clinically unstable because they have an occluded artery, they're actively infarcting. These are end-STEMI patients who've declared clinical instability in another way, and the list is there. Then if you have low-risk patients, we can be ischemia-guided. These are troponin negative patients with acute coronary syndrome. They're not having an end-STEMI. They're having, because their biomarker is negative or their TIMI score is low, we think they're less likely that this is a coronary event. Then your classic end-STEMI or the early invasive.
Well, but again, for the low risk, you can go through everything of calculating the GRACE, but if your troponin is normal and your ECG is normal, especially if they're a woman, you're done, right?
Correct. Yep.
Okay.
Exactly.
So I'm just trying to make this simple for you, not only as you take the boards to have to do these calculations, but in life, those two things are probably the most significant factors.
Correct.
Okay, then keep on going. So early invasive for.
So these are, again, this is your classic end-STEMI. This is the guy that we described in the question stem. Positive biomarker, ECG changes. These add a lot of specificity that this is a coronary event, an ischemic coronary event, so the benefit is much higher to going straight to the cath lab, and that's where that is. It doesn't have to be urgent, immediate, unless there's clinical instability. So these are people same day, next day that you want to cath, but within 24 hours. And then there's this delayed invasive strategy, and the way that I think about it is these are people with high enough pretest probability that an ischemia-guided strategy isn't going to keep you from going to the cath lab, but maybe there's a way that you want to optimize them medically before coming into the cath lab. So it doesn't have to be so soon because you're not so certain that it's an ischemic coronary event, but their pretest probability because of their clinical circumstance is high enough that an ischemia-guided strategy isn't going to be fruitful.
Yeah, and a lot of these, like the diabetes and the lower ejection fraction, is you want to cath them because even though they might be stable, they might have the anatomy by which you can improve their survival. So that's kind of the rationale for the delayed invasive. If we go back to Chet's talk, if we see proximal three vessel disease, especially in a diabetic, or we have a patient with an ejection fraction that's less than 40%, it's very reasonable to cath them, not because you think they're going to become unstable in the future, but because you might find an anatomy in which you would improve their survival by revascularization. And I think that's Peter's kind of bottom line about that last box he's talking about. Okay? So I think that's become clearer over the years as to when to go to the cath lab for non-STEMI. So let's next turn to the next question. So now we want to know what we're going to do for STEMI. No doubt that if you're in a PCI hospital, STEMI comes in, you're going to shoot them up to the lab. You got to have all systems go, get them in as soon as possible. But now, you work in a community hospital 60 minutes away from the nearest referral center with subspecialists. So you have to know where you're working and how far away or how long it's going to take to get there. You have a 60-year-old guy, he's got PAF, he's woken with left arm chest discomfort, persists for about 30 minutes, presents to your ED 45 minutes after the onset of symptoms. Denies other complaints, just flew from Hawaii, so there's kind of this question of maybe a DVT. He's on metoprolol, apixaban, atorvastatin, DIG, no medical or food allergies. His exam is normal. Next slide. He started on morphine, he started on oxygen, and now pain-free. And his labs, his chest x-ray is good, troponin is pending, D-dimer is a little bit elevated, white cell count is a little bit elevated, but you're called to the ED to see the patient. Next slide, and you see this electrocardiogram here. Okay, so all of a sudden the lights go on. So you know what's going on now. So it's a 60-year-old man who had 45 minutes of pain, went to the emergency room, 30 minutes of pain, 45 minutes of pain, went to the emergency room, and now in the emergency room. Has that. Next slide. So what's the best treatment strategy for this patient? Start unfractionated heparin, get a CT angio, get a CT triple rule out, transfer to a referral facility for angiography and coronary intervention, bolus TNK and transfer to a referral facility, unfractionated heparin admit to your intensive care unit. Okay, most got it? Okay, Peter, go on to the next slide. And the next slide. Okay.
So I think inferior posterior STEMI in a patient is high bleeding risk because of the apixaban. And I think this is the really hard part with these DOACs or NOACs. It used to be you could just screen the INR and see whether they were on warfarin and you didn't have to worry about much. These don't have a laboratory markers. You have to just look specifically for when they're on the oral anticoagulants. It's a high bleeding risk situation to give thrombolysis. So I think that's the kind of patient that we would say you have an IMI and you need to transfer rather than give thrombolytics.
Okay, and if he wasn't on apixaban? You got 45 minutes of pain, inferior MI?
I think then it would be reasonable if you weren't on apixaban. You're unlikely to achieve the first medical contact of balloon time in that situation of 120 minutes. So ordinarily we'd be looking at giving thrombolytics. He has a relative contraindication to thrombolysis.
Yeah. So if he didn't have a contraindication to thrombolysis, he comes in within 2 hours. You can't achieve that first medical contact to opening the vessel within 120 minutes, you give him thrombolysis. Right?
Correct.
And then what was the difference? One of the questions is, what is the difference? You had a box of thrombolysis and you had a box of pharmacoinvasive therapy. Both of those you're going to be given thrombolysis, but when are you going to ship a person afterwards?
So the essence of the pharmacoinvasive strategy is that after thrombolytics, you transfer to a PCI-capable hospital and they get automatic angiography. Not automatic PCI, but automatic angiography to look for this after enough time has passed, and this is usually built into the system, but enough time has passed that they're outside the risk window following thrombolysis to be in the cath lab. And I think this has become the preferred strategy if you're at a non-PCI capable hospital, because some patients, and what happens here is that some patients, remember, thrombolysis doesn't open every clotted artery. Every closed artery isn't going to open, so some people will fail and need rescue PCI, and instead of just waiting to see how this patient who received thrombolysis is going to do, you just transfer, so when they declare, they're in a place where they can be treated. So that routine transfer and angiography has made it a preferred strategy from non-PCI capable centers.
Yeah, so pretty much everybody now should be transferred after thrombolysis if they're a candidate to undergo PCI or coronary bypass grafting. And one last thing I want you to comment on. Peter kind of talked about the PCI of the non-infarct related artery, which has been very, very controversial, and new data is coming out now. We used to say it was a class 3, don't intervene on the arteries. Now it's kind of in a 2B, maybe a 2A range. In your own practice, if you have a patient come in, let's say with a right that's 100% occluded, that's the infarct-related artery, and has an 80% mid-LAD, what are you going to do yourself?
I think that this hinges on the benefit to complete revascularization is there. It depends a lot on the patient characteristics. We will tend to allow them to get through their acute infarct. We're trying to balance them being lost to follow-up versus the benefit of a staged approach. So it'll either be prior to discharge or planned at follow-up in 2 to 4 weeks. Okay. Sort of our practice.